Hello, David.
Hello, Joseph.
Are you ready?
Yes, I'm ready.
Okay. One moment. Is it recording? Yeah, it's recording. So I've randomly chosen this case, and this was a 61-year-old male who was presenting with shortness of breath for 3 months.
Okay, yeah, first of all, I should say I'm excited today because I believe I'll be discussing a case from a different space. We've had a number of cases here, really interesting cases, but discussing this case, not knowing where exactly it's coming from, maybe from a different with, from a place with a very different epidemiology. I think it's interesting for me. So looking forward to seeing what I'll be learning from this case. Yeah, so I believe it's not the first time we talk about shortness of breath. It's a very broad complaint, and therefore I'll just give an overview of the way I think about shortness of breath. So shortness of breath, difficulty in breathing, I put them under the same bucket. And the way I think about it in terms of organ systems first. That shortness of breath can be originating from the respiratory system, from the cardiovascular system. It can be neuromuscular, it can be endocrine, it can be psychogenic. And then once I do that, I start thinking now anatomically. For example, if I zoom in on the respiratory system, then I start to think about shortness of breath in terms of airway disease, parenchymal disease, pleural disease. So that way. Uh, so maybe I'll just give a few examples. For example, when I talk about shortness of breath being respiratory in origin, there are things like COPD, asthma, and then cardiovascular. We'll talk about heart failure, as well as coronary artery disease like acute coronary syndrome can present with difficulty in breathing or shortness of breath. And then neuromuscular, you have things like myasthenia gravis, Lambert-Eaton myasthenic syndrome, ALS, GBS. They can all present with difficulty in breathing if they involve the respiratory muscles. And then psychogenic, someone with a panic attack can present with difficulty in breathing. So that's the way I think about it. But then base rate is base rate. The most common causes of difficulty in breathing are either respiratory or cardiovascular in origin. So I prioritize those, but then I also become vigilant in order to see that I do not overlook causes of shortness of breath from other organ systems. So more details.
Yeah, thank you for the good start. So 3 months ago, this guy started to experience shortness of breath that was progressive over
Oh,
time.
Joseph, you are muted.
Ooh. Yeah, I'm sorry. So this is the HPI. Can you hear me now?
Yes, I
Yeah.
can hear.
So 3 months ago, he started to experience shortness of breath that was progressive over time. And initially, he reports to experience SOB when walking faster or ascending a flight of stairs. But over recently, he's having shortness of breath even at rest. And he also reports cough that was productive with whitish sputum. And he also reports fever, chills, and night sweats. But over the past 3 months, he has lost 6 kg without changing his intake of meals or level of activity. 1 week prior to admission, he reports to wake up like 5 to 8 times to urinate every night, compared to his baseline where he would wake up like 0 to 2 times before that week. He denies chest pain, orthopnea, or PND. That's HPI.
Okay, this is very interesting. So I'll try to pick a few things here that can turn out to be signal that points me in the right direction. So we've already discussed the general overview of difficulty in breathing. And now there seems to be, so when difficulty in breathing, so this difficulty in breathing, first of all, is progressive. So initially when with, I should say, moderate to uh, extraneous exertion, and then at this point in time, the difficulty in breathing is present even at rest. And then something that seems to be signal here, that the difficulty in breathing is associated with cough, which was productive. Now, cough, if you hear someone with difficulty in breathing and cough, you can see that the overlap between those two symptoms is huge. It's very easy to associate difficulty in breathing with cough than, for example, to associate difficulty in breathing with increased the frequency of urination. I mean, uh, the 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 difficulty in breathing could be respiratory or cardiovascular, while if we talk of increased the frequency of urination, it's a number of meters apart in the genitourinary system. So uh, this the cough points me in the direction that we're probably dealing with something cardiorespiratory, but then we should be very careful in making that conclusion, because cough itself, while it localizes in the respiratory system, it can signal something outside the respiratory system. So you can have, for example, someone is having cough, but then the primary pathology is actually in the GIT. For example, someone with gastroesophageal reflux disease. So, but putting these two things together, I think it points me more in the direction that we're probably dealing with something in the respiratory system. It can be in the cardiovascular system, because even someone with heart failure can present with difficulty in breathing as well as cough, especially as we see that this difficulty in breathing is progressive. So I'm thinking more that at this point in time that probably we're dealing with something in the respiratory system or in the cardiovascular system. But then another thing which is which is striking here is that the patient reports fevers, chills, and night sweats, as well as weight loss. So I see some constitutional symptoms. I see some things that point me in the direction of inflammation. I think we've repeated this a number of times, that when I think about inflammation, there's a number of things I'm thinking about. So I'll prioritize infection in this patient. Uh, and infections that I think about, tuberculosis is a possibility. But then apart from tuberculosis, I think I'll very much think about endemic mycosis, because those are the closest differential for me when I think about tuberculosis. So things like histoplasmosis and the friends that you can know about: histoplasmosis, coccidioidomycosis, as well as paracoccidioidomycosis, and other endemic mycosis that you can think about. But then so that's about infections. And yes, there can be other infections that I'll probably try to think about later. But then another broader category is autoimmune disease. So autoimmune disease like sarcoidosis, most notably, I think sarcoidosis is a close differential of tuberculosis. And yes, we can also think about other autoimmune diseases, although I think that is the closest differential that I see here. So sarcoidosis, but you can think also of the others. So will the HPI at least does not tell us some other things that are pointing us in the direction of others, but we'll see the review of systems. And in terms of malignancies, I'll also think about lymphoma, most notably, but also some solid malignancies. Of course, lymphoma or hematological malignancies in general are the ones that commonly will present with these constitutional symptoms like fevers, chills, night sweats. But we also have some solid malignancies that can present with these constitutional symptoms. But I think especially lymphoma, that is among the differentials that I'm thinking about, that is the one which is high on the list. Now, the next slide. This patient, can I see? Yes. So 1 week ago, this patient is having nocturia. The patient is having nocturia, and so for those who followed before, I think Joseph discussed about the issue of increase the frequency of urination. The question will be, if we are dealing with increase the frequency of urination, are we dealing with maybe something is irritating the genitourinary system, like a urinary tract infection, or this patient is having a BPH, for example. Can I see the introduction? I think there is something that we are dealing with someone middle aged. I should remind, yes. So actually almost elderly, but still middle aged, a middle aged male, yes. So we could be dealing with something like BPH, for example, that is leading to this nocturia. But then, if we are not talking of something irritating the genitourinary system leading to the nocturia, we could be talking about polyuria, for example. That this patient is having an increased volume of urine rather than just increase the frequency of urination. So I think yet with the details that we have here, we see that there is increased frequency, but it's not clear to us if this is a matter of increase the frequency alone or increase the volume of urine. So I'll see if we can if we can make more progress on that later. So maybe we see more details that you have.
That's pretty impressive. So we move on. The view of other system was nothing significant. Past medical history. This guy has a migraine headaches that are under control. Family social history. He lives in Ghana. He doesn't smoke or drink. He's married and he's a retired teacher. Is there anything there, David, or should we proceed?
Okay, so on these ones, review of systems is unremarkable. So I was talking about autoimmune disease, and of course, as you can recall, some of the connective tissue diseases that we talk about that can be associated with respiratory symptoms, things like rheumatoid arthritis, SLE, uh, have a prominent joint presentation, which I was very eager to hear about, whether this patient has any joint pains, and whether there are also any presentation involving the skin or the integumentary system in general, because we know most of the connective tissue diseases that we talk about uh, may not just affect the respiratory system in isolation. So commonly, the respiratory system will be involved, but in conjunction with other organ systems, the musculoskeletal system as well as the integumentary system. So hearing things like joint pain, any skin rash, any oral ulcers, any hair loss, any nail changes. So we do not hear any of those here. So I would say at a point like that one, maybe thinking of something like SLE can be a little far-fetched, but we know that lupus, as we know it, uh, there is involvement of the kidneys, there is involvement of the respiratory system as well as the musculoskeletal system and the integumentary system. So, for example, someone can have lupus nephritis alone, no features of SLE, so we cannot completely throw it out. But for something like rheumatoid arthritis, again, I would expect a prominent joint presentation, which I do not see in this patient. But then the other autoimmune diseases or vasculitides, I should be more specific, like ANCA-associated vasculitides, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, as well as microscopic polyangiitis, which can involve the respiratory system as well as the kidneys, to be more specific. But the presentation, the textbook presentation we know about is that someone presents with hematuria, so features of a glomerulonephritis. And in the respiratory system, yes, cough and difficulty in breathing are present, but we expect more of hemoptysis. So that is the textbook presentation, not necessarily to be there, but that is what would trigger us to think more about that. So the review of systems being unremarkable, I think it makes me think less of most autoimmune diseases that I mentioned, but I think it does not completely rule them out. Now, the history of migraine, uh, does it have anything to do with the current presentation? I do not see a connection. If it's present, I think I'll sit back and learn from that later. And then this patient, we did not hear a history of, for example, because I mentioned some things, tuberculosis, I mentioned endemic mycosis. So this patient does not seem to have to have some features of immunosuppression, at least from the history that we can pick. For example, diabetes, although maybe the nocturia that we see here could be a presentation of diabetes. We talked about polyuria, but we do not see that here. The patient is not hypertensive. So basically, the past medical history was non-contributory. Uh, we do not see any signal that points us in the direction of immunosuppression, for example, from the history. That is my assumption at this point. The patient not smoking, uh, although solid malignancies, as I said, they are not very notorious for causing dramatic constitutional symptoms that we saw, for example, fevers, night sweats, and chills. Maybe they are not a common presentation in patients with a lung malignancy, for example. I'm thinking about lung malignancies and a possibility of a paraneoplastic presentation leading to something like polyuria. But then uh, I, I, I think if I think about lung malignancies, I think more of the syndrome of inappropriate ADH secretion rather than diabetes insipidus. So I think the connection there is a little far-fetched. But this patient not smoking, not drinking, I think especially the issue of smoking, it helps us at least think less of a number of differentials in the respiratory system like COPD or like lung malignancies, although they cannot be completely thrown out in a patient who does not smoke. So that's my take on these other components of the history. So let's hear more and see if we can make progress.
Okay, so we move on to the general exam. So it was alert and oriented. He was a febrile, not pale, not jaundice, no lymphadenopathy, no lower limb edema. His vitals were normal except for a respiratory rate of 24. The respiratory system exam, he was tachypnic at 24 cycles per minute, but the chest was clear. Cardiovascular system exam, he had regular rate and rhythm, no murmur. Musculoskeletal system exam, he had a swelling on the right thigh that was 3 by 4 centimeters diameter. It was non-tender and firm. Neuro exam and per abdomen were all normal.
Okay, so I see something is eye-catching here is the respiratory rate. Now with this patient, right from the complaint, we could think that this is a possibility because this patient is dyspneic at rest, and therefore a respiratory rate is a way to compensate, to make sure that uh, the blood is well oxygenated. So that's what we see here. But then uh, respiratory exam is clear. So uh, there are some other things that we could think about in a patient like this. The patient is having cough, is having difficulty in breathing, fevers, night sweats, weight loss. So at least some of the things can present with. We could pick some findings. For example, for something like tuberculosis and other things which affect the lumbar parenchyma, the respiratory exam can be completely normal. You do not pick features of consolidation, for example. But then some other things, for example, if we are dealing with something in the pleura, we could pick something like a pleural effusion, for example. or the patient is having difficulty in breathing, and therefore distant heart sounds would mean maybe we are having a pericardial effusion. We do not see it in this patient. So only tachypnea. And then this swelling on the right thigh, I cannot, I think I do not see many details that can help me to use my imagination and make out what this can be, because we are told it's a swelling on the right thigh. Not sure if this is the medial or the lateral aspect, whether it's anterior or posterior. But then those are the dimensions. It's non-tender and it's firm. We're not sure if it's mobile, if there are any skin changes. But then what could this be? This could be anything. For example, it could be a lipoma. Uh, it could be a lipoma. It could be a tumor, because we do not know the location. So if it's something on the thigh, it's very difficult to say this is a lymph node, because lymph nodes would be in the inguinal area, for example. So I'm not sure what to make out of this mass. Yes, neurological as well as abdominal examination are normal. So nothing much on the physical examination. Up to this point, I'm not sure what to make out of this mass, but maybe more details, other investigations that can help us make progress.
Yeah, so here are the labs. The full body picture was normal. Electrolytes, sodium and potassium were normal. Creatinine was 2, and like 3 weeks ago, his baseline was 1, so this was raised. But BUN was normal. Calcium, total calcium was 15.5, which is high. And also they send ionized calcium was also high at 2.14. AST and ALT were also normal. HIV was negative, RPR was negative, and they sent blood cultures times 2 times, and there were no growth. Something I forgot here. Also, they did ALP, which was elevated, like 241. Forgot to write it here.
Okay, so that's it for the labs.
Mm-hmm.
Okay, nothing very significant. From the CBC, the WBC count is normal. Uh, he has a normal HB. This patient has been sick for about 3 months. The HB is normal. Platelet count is normal. So the electrolytes there, sodium as well as potassium, are normal. So this creatinine signifies acute kidney injury, because if the baseline was 1 week ago, that's a more than 50%. That's a more than 50% increase from baseline. So this patient has acute kidney injury. So the next thing will be to establish the cause of this acute kidney injury. The blood urea nitrogen is normal. So what's striking here is hypercalcemia. Now, hypercalcemia is a very tricky thing. We do not see any signal coming out of the liver. There is no hepatocellular injury. HIV is negative. Again, removing another cause of immunosuppression. So diabetes, we do not hear any history of transplant or anything like that. And HIV is negative. RPR is negative. Blood sugar, no growth. So I think I'll dwell around the discussion of this calcium. So calcium is very tricky, and I think I'll spend some time discussing calcium. And it's clear that this patient is having true hypercalcemia. Because sometimes you can do total calcium and you see it's elevated, but the reason could be this patient is having an increased level of serum proteins, especially albumin, and calcium is extensively bound to albumin. So that could imply just an increase in the level of albumin. But then when you see that the ionized calcium is high, that means this person is having true hypercalcemia. Now here is my approach to hypercalcemia. Hypercalcemia, I think of it in terms of PTH and PTHRP related. So PTH is parathyroid hormone, and PTHRP is parathyroid hormone related peptide. So that is one. Or maybe in order to I should use another simpler one, which is just PTH related, and then I'll talk about malignancy related, and then vitamin D related, and then related to the kidney. So with PTH, you can have primary hyperparathyroidism, primary hyperparathyroidism. So hyperparathyroidism and thyroidism. This is hyperparathyroidism, and this could be due to adenomas or carcinoma, or the hyperparathyroidism being part of multiple endocrine neoplasia. So that's for primary. And then you can also have PTH related as a result of what is called familial hypocalciuric hypercalcemia, which is an inherited problem, and it's due to mutations in a receptor which is responsible for sensing calcium levels and bringing out feedback mechanisms in order to ensure that the levels of calcium are within normal range. Now, we did not hear anything that is, at least in the initial presentation of this patient. Cough is not a primary presentation of hypercalcemia or difficulty in breathing. So the presentation of hypercalcemia, mental status changes, polyuria can be a presentation of hypercalcemia. So because we have an elevated level of calcium, one of my closest, one of the causes of polyuria, especially the nocturia, that is close to my reach now is this hypercalcemia. Hypercalcemia can cause polyuria. So maybe that could be the explanation for this patient's polyuria. And another thing, of course, I mentioned mental status changes. These patients become anxious. They become anxious. So all these are part of the mental status changes. And then another thing, of course, in the cardiovascular system, a shortened QT interval, a risk of arrhythmias, and then they can have a presentation in the GIT like constipation, peptic ulcer disease, nausea, vomiting. We did not see any of that in this patient. So the thing is, what is the cause in this patient? Of course, primary hyperparathyroidism is a possibility, but then it does not explain this patient's cough and difficulty in breathing. PTH RP related or malignancy related. So squamous cell carcinoma of the lung, breast carcinoma, as well as pancreatic and renal cell carcinoma, those ones can produce PTHRP, parathyroid hormone related peptide, which now functions in the same way. They activate the same receptor, that is the parathyroid hormone receptor type 1. But then we did not hear risk factors for a lung malignancy in this patient, but because the patient is having cough, is having difficulty in breathing, we can consider a possibility of a lung malignancy that could cause the hypercalcemia. So, but I'll keep that one low on the list because, as I said, solid malignancies are not very heavy on constitutional symptoms that I talked about. Now, apart from PTHRP, now we come to vitamin D related. And vitamin D, it can be either intoxication with vitamin D, someone is taking in too much vitamin D, or it can be abnormal metabolism that leads to increase the production of vitamin D. There's a number of things that can do that, which are a possibility in this patient. So one, all granulomatous diseases can lead to abnormal metabolism, which leads to an increased production of activated vitamin D. So sarcoidosis, tuberculosis, they can all do that. And so with up to this point, I could be wrong, but then I think I'll seriously consider those things, sarcoidosis as well as tuberculosis, because they are granulomatous diseases, and those granulomas can produce vitamin D. And now this activated vitamin D is leading to increase the GI absorption of calcium, leading to elevated levels of calcium. So I think those are the ones which are closest on the reach here. So that's how I approach hypercalcemia. Now connecting these things, I think granulomatous diseases are high on the list, sarcoidosis, tuberculosis, and then I'll also consider possibility of a process in the lungs. So I'm talking about a tumor, I'm talking about a malignancy, like squamous cell carcinoma, but we do not have risk factors for that. And I think the constitutional symptoms, especially the fevers, the night sweats, the chills, make me think more of these granulomatous diseases rather than the solid malignancy. So sarcoidosis, tuberculosis, and I will not throw out the endemic mycosis because they're also granulomatous diseases. So that is where I am at this point in time.
Yeah,
Any more details?
that's pretty impressive. I loved how you've mastered the hypercalcemia approach. So I said another thing is this patient had an elevated ALP with a normal GGT. Can you connect that with these other labs?
Okay, so alkaline phosphatase comes out from a number of things. Of course, we know the liver is one of those, but then the liver, um, the liver is paired here. We see ALT, unless we are talking of something, uh, biliary, which we do not see here. So ALP also comes from bone. ALP also comes from bone, and therefore. Uh, and of course that the other thing, thank you for reminding me, because if I overlooked the ALP itself, that is the importance of taking things holistically. So ALP in this patient would imply uh, increased bone turnover, and if we are talking of increased bone turnover, I think we should consider PTH and PTHRP very seriously, because vitamin D works predominantly on the GIT as well as the kidneys. But parathyroid hormone and PTHRP, they work predominantly in the kidney and the bone. So an elevated level of ALP, I think I should seriously consider differentials that are pointing me in the direction of bone. And if I think about something takes me to the bone, so it's either PTH is elevated, leading to increased bone resorption, uh, and therefore ALP, of course, would be one of the things that we see elevated, or we are talking about PTHRP doing the same. And therefore, if we think about PTH, we do not see anything primary about this one, thinking about an adenoma, thinking about carcinoma or multiple endocrine neoplasia, we do not see any signal that points us in that direction. So I think we should also consider a possibility that we are dealing with something that has to do with PTHRP. And of course, another thing that I did not talk about is you can have hypercalcemia from increased bone turnover. Uh, and increased bone turnover, of course, now it's things like vitamin A intoxication, medications like thiazide diuretics, which we do not see here. Immobilization can cause increased bone turnover. Hyperthyroidism can cause increased bone turnover. We do not see any signal that points us in that direction. Now the question will be, what is causing increased bone turnover in this patient? So it could be PTH, it could be PTHRP, and the granulomatous diseases that I talked about. I think I should also consider them, but then out of those now, they are not known to cause increased bone turnover, at least by themselves. Hematological malignancies, of course, hematological malignancies associated with hypercalcemia. So myeloma, for example, um, as well as lymphoma. I talked about lymphoma and leukemia itself associated with hypercalcemia. So yeah, I think I'll step back and see maybe what else could explain, especially the ALP. So I think PTHRP should be considered very seriously here. So thank you for reminding me about ALP.
Here's the chest X-ray of the patient.
So what I see in this chest X-ray, uh, so basically it's a number of opacities. I see. So first of all, it's a reticulonodular. I see a reticulonodular pattern, which is bilateral. And what I see at the top, I'm not sure if I should say those are lymph nodes on the right. So on the right middle to upper zones, if we talk in terms of zones, you see those opacities right there. So I am not very confident to say that those are lymph nodes, but also on the left we see almost the same picture. We see a bilateral picture here. So it's something reticulonodular. It can be anything. For example, sarcoidosis could cause something like this, and then tuberculosis, if it's miliary, we can see something like that. So again, you see I'm circling almost around the same, talking of the same things, sarcoidosis, tuberculosis. I would also think about the endemic mycosis that I talked about. I wouldn't expect a picture like this from a primary malignancy, like for example, squamous cell carcinoma of the lung, which is not known to be metastatic, at least early on in the course of the disease. Uh, so I mean, with this X-ray, if you have a formal report, maybe you can help tell me the things that I missed. But those opacities, I see some things which I'm not sure to say they are lymph nodes or not, but also a reticulonodular pattern. So I'm concerned especially about the granulomatous diseases that I already mentioned early on.
I think the radiologist report was on the same lines. At the end, they concluded it at a miliary pattern chest X-ray. So maybe we move on. So the team ordered further labs because of this X-ray, and this included an AFB sputum that they repeated 3 times, and every time it came back negative. Strongyloides IgG was negative. Blastomyces antibody was negative. Histo negative. Urine histo also normal. Aspergillus antibody is negative, and beta D glucan was also normal. They also did a lower extremity ultrasound because of that mass, and they found a DVT in the in the distal right femoral vein, and also the swelling was thought to be a questionable mass on the right thigh, posterior to femoral artery and vein, and they recommended MRI.
Okay, so yes, this slide here, I'm happy that they did these investigations because you can see that at least most of the things that we mentioned have been investigated here. So tuberculosis, and then the endemic mycosis that we are talking about. So especially, I should say, out of these, uh, histoplasma antigen in the urine is something very specific and sensitive. So not picking it, I think at least there is a good chance that we are not dealing with this. But we should also keep in mind that uh, we should also keep it in mind that the test characteristics are not perfect. The sensitivity is not 100%, but I think beta D glucan is something that we that is positive or is found elevated in a number of these mycoses that we talked about, especially the dimorphic ones. I think only a few, like I think Candida possibly, as well as Cryptococcus. So they are the ones which are, especially Cryptococcus, they are the ones which do not have beta D glucan. So it's not specific for any particular fungus, but then it is something that is shared among many fungi. But then, as we can see the panel here, they tested a number of things that we are talking about, which are negative. Now, AFB sputum being negative 3 times, I think we all know that, of course, the patient, we see that is a miliary pattern, and therefore we would tend to think that there was a good chance that with that, we could see that maybe the AFB burden would be very high in the sputum, and therefore it would turn out to be positive. But then it's negative here. But then I think I would also need to do gene expert, because I believe gene expert is more sensitive than AFB. But with this picture and it being negative, I think of course it lowers our confidence in tuberculosis. But I think I'll still entertain tuberculosis. Now the next slide. So there is a DVT and then a questionable mass. So what exactly is this mass? What exactly is this mass? It's a mass on the right thigh posterior to the femoral artery and vein. So it's something deep in the tissues. If I get right what they mean, it's something deep in the tissues, because if it's posterior to the femoral artery and the femoral vein, so it's something in the deep tissues. Now, what exactly this? I think I maybe further imaging, I think, can help me clarify this. But then my other question is why this patient is having a DVT. So something in this patient is causing them to be hypercoagular. What exactly is it? We are probably dealing with the malignancy, especially the suspicious mass. I'm not yet sure what to make out of that. So if you have any other details that can help me get more clarity, let's have them.
So the ordered MRI is suggested by the ultrasound dye. It showed posterior right thigh soft tissue mass, which measured approximately 4 centimeter.
Hmm. Do you have anything else?
This is the end. You have to commit for a diagnosis.
Okay. Okay. So uh, I think with all the details, I think yes, we've made a little progress. But then, I mean, I think I've come to a point where I'm stranded. Uh, so I'll go back. So we have a 61 years old male with an unremarkable past medical history apart from migraine, which was well controlled. And this patient presented with difficulty in breathing or shortness of breath for 3 months. So that is something a chronic. So presenting with chronic shortness of breath with constitutional symptoms of fevers, night sweats, weight loss, uh, and then uh, this patient also presented with polyuria, which started 1 week prior to presentation. And then on investigating this patient, of course, physical examination was only remarkable for tachypnea, but the patient was not hypoxemic. The oxygen saturation was 98 on room air, if I remember correctly.
Yeah.
So the patient was not hypoxemic. But so, and then physical examination was notable for a mass on the right side. Labs were notable for hypercalcemia and acute kidney injury. Now, I think I would associate the the acute kidney injury to hypercalcemia. So hypercalcemia itself can cause renal insufficiency, but then of course it could be the pathology that we have not yet established. But then the calcium, I think we already discussed the approach to hypercalcemia. Now, what exactly among these things is telling us what is happening? We have a mass. Now, a soft tissue mass, I mean, in my reading, and of course, I cannot confidently say that I have read enough to say confident that the mass that we see is not a cause of this presentation. But I think I already mentioned that because I'm trying to connect to find something, a single thing that can explain all these things. The picture that we see, so the shortness of breath, uh, the constitutional symptoms, the miliary pattern that we see on the chest X-ray and the hypercalcemia, as well as the elevated ALP, alkaline phosphatase. And imaging is telling us that this is a soft tissue mass rather than something in the bone. So I'm thinking, what kind of, if we are talking of a soft tissue mass, we know the soft tissues that we see here is not the skin because it's behind the arteries and the vein. So is it a mass? So now I'm trying to think. So probably we are dealing with the soft tissue sarcoma. So that's the dilemma that I have. That in my reading, at least among the causes of hypercalcemia through the mechanism of PTHRP that we talked about, I do not remember reading about soft tissue tumors like sarcoma or something like that. And I'm not sure if these sarcomas are also heavy on constitutional symptoms like fevers, night sweats, and weight loss. And then the picture that we see, could it be a granuloma, for example, in the soft tissues, a granuloma from tuberculosis or a granuloma from sarcoidosis? And of course, they did not do angiotensin converting enzyme, which is one of the things that can point in the direction. If you see elevated levels of ACE, then your suspicion for sarcoidosis increases. Because the chest radiograph for me is concerning for sarcoidosis, is concerning for tuberculosis. It was concerning for endemic mycosis, but I think with the labs that we had, I think those ones are on the list at this point. So I'm still concerned about tuberculosis, about sarcoid, but then I will also entertain the possibility that we are dealing with a malignancy, for example, a soft tissue mass that is producing PTHRP, although I've never come across this. So I think I will not be able to commit to a single diagnosis, but then let's just keep those three that we are dealing with tuberculosis, sarcoid, or a malignancy. So there is a possibility that the final diagnosis falls under one of those, or maybe not, but those could be close differentials, especially now we know when we talk of lymphoma, for example, lymphoma, it's in the lymph nodes. Now, that soft tissue mass, is it lymphoma? I'm not exactly sure. So let's just hear what the diagnosis was.
Yeah. What do you think caused that?
Uh, cause the okay, so I think the cause the closest cause of Aki here, because if I use system two thinking, we know Aki is pre-renal, renal, and post-renal. We do not see anything pre-renal here. There is no vomiting, there is no blood loss, no nothing. So post-renal, we do not see any features of obstruction. So it's something in the kidney. So something is injuring this kidney. And I think the cause of VAC in this patient probably was the calcium, because we see that this patient has been experiencing polyuria, uh, especially nocturia, for the past 1 week. And the creatinine that was done 1 week prior was normal, and now it has doubled. So I think probably the calcium, but then it could be the primary process that is the cause of the ACI.
Sure, I agree with you. Yeah, so I think it's pretty much in the same line as you were saying. They had a presumptive diagnosis of sarcoma for the mass with lung and bone mets. And if you do like this, it can explain all the things that are there. Like lung mets, hematogenous lung mets can present with that miliary pattern chest x-ray. Bone mets can explain hypercalcemia, and hypercalcemia can explain the polyuria and the aki that is this patient is having. So they had their own teaching points here. Initially, as you did, they highly suspected, since patient lives in Ghana, highly suspected miliary TB, and they started the patient on an empiric quantity B. But they sent sputum for AFB repeated 3 times, still negative, and they realized maybe it isn't TB, and they stopped the anti-TB. This is important even in our setting. We see people coming in with suspect TB, we sent AFB is negative, even Gene Express negative, and we just stopped there and started anti-TB, only for the patient not to respond and realize maybe it's not TB. But we can copy from this. I did this once, and the lab said no, they can't repeat AFB. They said we have done it's negative. So you can maybe convince them, because the most common cause of a negative AFB in a patient with TB is poor sputum sample, because no one is telling those patients what you have to give us. They give, right? They give us saliva sometimes and not the sputum. And so they biopsied the mass, which showed chondrosarcoma. They initiated chemo with pazopanib and later changed into sunitinib. They centered their discussion around the medial pattern chest X-ray at the center of gravity of this case that could have brought up the final diagnosis. So miliary means millet seeds, which translate into what we see on chest X-ray, 1 to 2 millimeter nodules in diameter, and there's a broad DDX, not just miliary TB, which is common by the way, and you should consider it here. But there are other things that you were talking, like histoplasma, sarcoid, but I wouldn't say sarcoid. I can say sarcoid because after they have maybe CT, and you realize there are no like big nodules, you realize maybe it's not sarcoid. And then hematogenous spread of cancers, metastasis, which was the case in this which is diagnosed in this case. So thank you very much. That's a nice a nice discussion. One point that I think it should come clear is yes, your approach of hypercalcemia pretty nice. I loved it, but I think it's either the calcium is driven by hyperparathyroid hormone or not. And if it is driven by hyperparathyroid hormone, is the things that you said, like you can have parathyroid hyperplasia, parathyroid malignancy, and others. But if it is not driven by parathyroid hormone, other things that can drive it include the parathyroid RP, like a peptide that is released by squamous cell cancers of the lung and raise the calcium. And the others is vitamin D intake, as you're saying, and bone. So since it is not squamous cell carcinoma, it wasn't because of the PTHRP. It was because of the bone turnover that been having a Mets. That's why we are also seeing ALP elevated. But yeah, thank you. Maybe a reflection from you.
Thank you very much. I think this is a very interesting case, very well chosen. Yes, I mean, you see, I think this highlights how complex clinical reasoning can be. I think I've learned a lot actually. You see, so the approach to hypercalcemia is, of course, I mentioned a number of things, but I think one of the things that did not come out very clearly was the issue of bone mets themselves, regardless of so hypercalcemia, which is not due to PTH or PTHRP, but then the bones are involved, and that's if anything metastasizes to bone, for example. I think that is one of the things that I did not talk about, at least initially. So, I think that was the other thing that I should have considered, and I was actually thinking about it, but then the fact that the pattern that I saw on the chest X-ray was more of miliary, And then, when we think of lung meds, we commonly think about cannonballs rather than a miliary pattern. So I think that is one of the new things that I've learned today, that with hematogenous spread to the lungs, you can have a miliary pattern, and it's not due to TB, not due to sarcoid or any of the endemic mycosis that we are talking about. So I think that is one of the things that I did not have much clarity on. And although yes, I mean, a soft tissue mass was within my last three differentials, I think I was off track on the mechanism of the hypercalcemia, because I was thinking in the lines of PTHRP, forgetting bone mets, because the ALP, I was trying to fit it in the picture, but in the line of increase the bone turnover from either PTH or PTHRP rather than bone mets. I think that was the key to the diagnosis. So that's new knowledge that I learned today, and I think it's been a very good exercise for me. I thank you very much for the case.
Yeah, you're welcome. And another thing, when I solved this case, I paused and reflected on why every one of us now should consider learning medicine in a case-based approach. Because if you listen to David, he started up there with SOB, right? That's a completely different problem. And then moved in the case, you find other problems. Someone is having ARP with a normal GGT, you translate that. Someone is having hypercalcemia. And David is telling you total calcium, ionized calcium, there is meaning there. And then you go again, um, you find a mass, you think of what are the possibilities if I see a soft tissue mass on MRI or another DDX. So this approach of learning medicine as we were taught, like when we were in schools back then, sitting and listening to a lecture, is good, but very insufficient. But if you solve a case like this, and maybe even if you are solving and reading around, like, okay, what are the differential diagnosis? How do I approach hypercalcemia? You gain a lot of knowledge. So we are doing AfroDX because we emphasize a case-based approach of learning medicine, and we really learn a lot. Yeah. So, do we have anything else from anyone else? Like a question, an addition, um, anything? We haven't heard from you guys. Like it's just me, David, and some some Sebastian. Anyone else? No one. Okay. We'll be here once again next week with the real case from Tanzania. David, should I say good night?
Yeah. I think we already beyond time, just a few minutes. I think it was a good discussion, but within time. So thank you very much, everyone, for joining. Looking forward to next weekend. So we hope to have you back here next weekend. Good night.
Good night.